Hello everyone, hope you're all doing good. This is Dr. Agalya Kulandevelu, your organic faculty, and in this video we are going to discuss about leiomyoma. Leiomyoma is nothing but the fibroid. It is the most common benign tumor in women. It is the most common benign tumor in women, and this arises from smooth muscle of uterus. Okay, smooth muscle cells of uterus. Okay, so this is very important. Next one is, this also contains varying amount of fibrous tissue as well, right? Fine. Now, let us see what are the risk factors for leiomyoma. Risk factors for leiomyoma include age, especially in the later half of reproductive age, say 30 to 40 years. Then the race of the woman, it is 3 to 5 times more common in African people. If the woman had early menarche, she was an nulliparous woman. She was a case of obesity, diabetic mellitus, PCOD. When she had high blood pressure, that is, she was a case of systemic hypertension. There was a history of addiction to caffeine and alcohol. And finally, due to the hormones, okay, that includes both estrogen as well as progesterone, but the action of estrogen to produce a fibroid is more when compared to progesterone, and sometimes, genetics also can play a role, especially the fumarate hydratase gene mutation. Okay, fumarate hydratase gene mutation that can lead to hereditary leiomyomatosis, renal cell cancer, as well as cutaneous cancer also. Okay, and I wanted to tell you, I want you to tell one interesting fact also. Here you have to know, smoking reduces the incidence of fibroids because smoking is going to reduce the level of estrogen levels, right? Yes. Now, let us see the pathogenesis of fibroid. Pathogenesis for leiomyoma, you have to understand, each leiomyoma develops from one single smooth muscle cell of uterus. Okay, so each myoma develops from smooth muscle cell of uterus, which will be a single cell. Okay, and you may even see chromosomal abnormalities that will include translocations, rearrangements or deletions. Okay. Then abnormalities in angiogenic growth factor have also been implicated. Okay. So, these growth factors can include your transforming growth factor, epidermal growth factor, insulin-like growth factor, then GM-CSF. Okay. Granulocyte monocyte colony stimulating factor, right? Yes. So, not only this, there is also another pathophysiology given, that is elevated cytokine levels that will stimulate the mitotic activity. So, that increased mitotic activity will be giving rise to myoma. Clear? Right. Now, let us see the pathology. Pathology, first let us see the gross appearance. So, gross appearance of myoma. This can be a single myoma or multiple myoma. The shape of the myoma can be round or oval. The consistency will be firm, and sometimes this firm consistency can be turned into soft if there was any degeneration present. Usually, myoma is covered by a pseudocapsule. This is covered by a pseudocapsule. Cut surfaces are going to show rolled appearance, and the center of the myoma is pale than periphery of the myoma. This has a white and glistening appearance. Okay. Now, let us see the gross appearance once again. Before that, let me show the picture, okay, so that it will help you to understand it better. Okay, so this is going to be the gross appearance. So, this is how it is going to be. Okay, so this is the gross appearance of myoma. So, I have told you a myoma in a woman can be single or multiple, okay, and this can be a round shape or even a oval shape. Yes, it is covered by a pseudocapsule. So, here in this picture if you see, there is a pseudocapsule. Okay, so this is all the myoma. Okay, so till this it is the myoma, and the green thing what they have shown here is the pseudocapsule. Okay, so what is pseudocapsule? Pseudocapsule is nothing but the compressed myometrium, okay, that is surrounding the myoma. Okay, so that is pseudocapsule, and deep to this pseudocapsule layer you will have the plane of cleavage. So, through that the myoma can be extracted while doing a surgery. That is the importance of this pseudocapsule. Okay, and then if you see the consistency, I told you it is going to be a film consistency, and if you see the cut section, there are going to be a rolled appearance. Okay, rolled appearance means, see, in this picture you are able to see. So, this is a rolled appearance of fibroid, you are able to see like this. Okay, so this is a rolled appearance of fibroid. Okay, and the center is going to be pale than the periphery, because if you see how is going to be the blood supply of the fibroid, you have to know. So, the fibroid will be supplied like this, right. So, from all the ends it will be supplied like this. So, the periphery will be getting more blood supply, and as it gets to the mid portion of the fibroid, the blood supply here will be lost. So, that is why the center is going to be pale than the periphery of the fibroid. Clear? Right. Now, let us see the microscopic appearance of fibroid. Microscopic appearance of fibroid. When you see the microscopic appearance, generally we know the size of the uterus is going to get increased, right. So, size of the uterus is increased, endometrial cavity is distorted, okay. Endometrial cavity is distorted, and then all vasculatures become dilated, and then if you see in general, the size of the uterus is increased, endometrial cavity is distorted, and finally all vasculatures become dilated. Clear? I hope you would have understood. Now, let us see the microscopic appearance of fibroid. So, when we speak about the microscopic appearance of fibroid, the composition in fibroid is going to be smooth muscle and connective tissue, okay, and non-striated muscle fibers are arranged in bundles that run in multiple directions, okay. So, these are the 2 points, and then if you take and see an individual cell through microscopy, individual cells are spindle shaped, they have an elongated nuclei, and they are uniform in size, and one important point is you have varying amounts of connective tissue, that is intermixed with this smooth muscle bundles, okay. So, this is all about the microscopic picture. So, you will be able to see a smooth muscle and connective tissue, that is the composition we all know, and what happens means you will be able to see non-striated muscle fibers that will be arranged in multiple bundles in multiple directions, okay. Individual cell will be spindle shaped, elongated nuclei will be there, and it will be uniform in size only, and you will be able to see varying amount of connective tissue in between the smooth muscle bundles, okay. So, this is the picture, microscopic picture of a leiomyoma, okay. So, this is a cell, okay, this is a smooth muscle cell that is elongated, okay, and here you are able to see numerous connective tissues, okay. So, these are the dilated vascular channels. Clear? Right. Now, let us discuss about the secondary changes in fibroid. So, secondary changes in the fibroid. This include degenerations, that means hyaline degeneration. So, hyaline degeneration is the first one we are going to discuss. So, this is one of the most common type of degeneration happening in a fibroid. And it occurs due to impairment of blood supply. When this happens, the fibroid actually feels soft. Cut section will show homogeneous appearance. The rolled appearance will be lost. And then, there is loss of rolled pattern. Okay, so this is all about hyaline degeneration. It is one of the most common type of degeneration that is happening in a fibroid. Clear? Right. Now, let's see how this hyaline degeneration actually looks. Okay, so this is the microscopic appearance of a normal fibroid. Okay, so this is the microscopic appearance of a normal fibroid, and this is the microscopic appearance of a fibroid which has undergone hyaline degeneration. Okay, so can you see the changes? Okay, so the rolled pattern is lost, the pattern is completely changed here, and it has become more smooth to see. Yes, so this is how the hyaline degeneration will be. And the next degeneration we can have is fatty degeneration. So this is very understandable and imaginable also, right? Yes, there are fat globules in the cells. Okay, you will be able to see an yellowish discoloration. Okay, and the next one is very important type of degeneration we are going to discuss, that is red degeneration. So, red degeneration is otherwise known as corneous degeneration. Okay, corneous degeneration. So, this usually occurs in pregnancy, and the change occurring here is coagulative necrosis, and here there is obstruction of vascular supply, and also there is hemolysis of RBCs. What happens means, you will also able to see hemorrhage and pigmentation on cut section. So, here the woman will be presenting with severe abdominal pain. Okay, severe abdominal pain. There will be fever, leukocytosis, and high erythrocyte sedimentation rate. Okay, so this can be managed with NSAIDs. Okay, NSAIDs are the mode of management. Clear? So, let me show a picture of red degeneration. So, this is a picture of red degeneration because there is hemorrhage that is happening inside the fibroid, and there is hemolysis, everything. So, you will get a red color picture of the fibroid. Yes, right. Now, the next type of degeneration we are going to discuss is calcific degeneration. Calcific degeneration means there is deposition of calcium salts, and this happens mostly in the post menopausal women, there is radio opaque deposits which are seen when calcific degeneration is happening. Okay. So, let me show you a picture. So, yeah, calcific degeneration can be seen even through a pelvic X-ray because these are radio opaque. You are able to see the calcified fibroids here, right? Yes. The next one is cystic degeneration, where there is liquefaction of the hyalinized or necrosed areas. Okay, basically, if you see here, cystic spaces are seen. Okay, so let's see a picture for it. Yeah, so this is liquefaction. Okay, so here you are able to see the whole material had gone for liquefaction. Okay, and you will be able to see cystic spaces like this in ultrasonogram. Okay, yes. The next one is myxoid degeneration, where you will have mucus fluid filled spaces. Clear? So, that's all, right? Okay. Now, let's see the classification of, repeating. So, that's all about the that's all about the degenerative changes that is happening in the fibroid. Let's discuss about the clinical classification of fibroid. Clinical classification of fibroid based on the anatomical location. Okay. So, if you take uterine fibroid, this can be divided into body or corpus, and that is happening in the cervix because that is the two parts of uterus, right. So, one that is happening in the fibroid can be further classified into an interstitial type, which is about 60%, and then subserous type, which constitutes 20% of the fibroid, and then submucous type, which constitutes 20% of the fibroid. Okay, and cervix means it can be anterior, posterior, central or lateral in location. Clear? Right. Now, this is the general anatomical classification of fibroid. However, we also have a subclassification of fibroid. Okay. So, when we see the subclassification of fibroid, it can be SM, that is submucosal first, and if you take submucosal fibroid, this can be pedunculated, less than 50% intramural and more than or equal to 50% intramural. Okay, and these are given numbers 0, 1 and 2 respectively. Clear? And the next one is the O. It is represented by the letter O, that is other types of fibroids. In these fibroids, we can classify it as one that is contacting the endometrium, but still it is 100% intramural. Yes. Then the perfect intramural one, it is not contacting the endometrium, and then the subserosal one, which is more than 50% intramural, then the subserosal one, which is less than 50% intramural, and a subserosal pedunculated fibroid, and the other types as well, which will include the cervical fibroid and broad ligament fibroid. Okay. So, this number will be continuing here, 0, 1, 2 is over. So, here it is 3, 4, 5, 6, 7 and 8. Clear? So, this is easy to remember, no need to worry. What we have to do is, we have to imagine a uterus first, okay, and imagine that a fibroid is going from the inside to the outside, okay. So, that is it, okay. So, first one, it is a submucosal fibroid, 3 types we have, right. So, submucosal pedunculated is type 0, and the submucosal, just I am giving a rough idea, so do not mind about my diagram, okay. Then it will be a submucosal, let us draw the myoma, let us consider this is a myometrium, so it will be easy for you, okay. Then that is one which is going outside, but it is less than 50% intramural. So, like this, okay, it is less than 50% intramural, and the next one becomes more than 50% intramural, okay. Can you see the difference between the two? Yes, like that. And finally, the one that is contacting the endometrium and it is completely intramural, okay. Then the one that is 100% intramural, but it is not contacting the endometrium, and then the subserosal one, which is more than 50% intramural, okay. So, that means it is more than 50% intramural, but it is also protruding outside through the serosa. And the next one, which is more than 50%, first one is more than 50% intramural and the next one is less than 50% intramural, and then comes the subserosal pedunculated type, and finally your cervical fibroid, and here you will have your broad ligament. So, a fibroid that is present in the broad ligament, okay. So, these are type 0, 1, 2, 3, 4, 5, 6, 7 and these are 8, okay. So, I hope this classification is clear for you now, right? Yes. Let us see about each type of fibroid separately. So, first one I want to discuss to you is about interstitial or intramural myoma, okay. So, here all leiomyomas starts growing intramurally only, okay. Initially they are intramurally only, then they can either remain as intramural or grow towards the endometrium and become submucosal or goes towards the perimetrium and become subserosal, clear. So, that is the importance of an intramural fibroid. And next one is submucosal fibroid. So, this is also very important type of fibroid, but it is less common, okay. So, this is less common. What happens we have already seen, okay. So, it remains partly in the myometrium and partly it may project into the uterine cavity, okay. Or remember, this is also possible, it may prolapse through the cervical canal also. So, when it is prolapsing through the cervical canal, it can even cause inversion of uterus, clear. So, that is the important thing. And another important point about the submucosal fibroid is that the clinical importance of submucosal fibroid, this is the most common type of fibroid that is leading to infertility in women, okay, right, because this is going to hinder with the implantation, right, yes. Next one, subserosal myoma. Subserosal myoma projects from the uterine surface. This is covered by peritoneum. A subserosal myoma can be sessile or pedunculated. It may grow inside the broad ligament, and that time when it is growing from the uterus into the broad ligament, this will be called as pseudo broad ligament myoma. Okay, but a broad ligament myoma means it should develop in the broad ligament itself. Okay, so that is a broad ligament myoma, but when it is growing as an extension of the uterus into the broad ligament, it will be classified as a pseudo broad ligament myoma, right? Yes. Then one importance of the subserosal fibroid is that subserosal myoma can become adherent to the intestine or omentum, and from there it gets blood supply and lives for some time, and finally from there also it will get detached and it will be wandering then and there. Okay, so it will be called as a parasitic fibroid or a wandering fibroid. Okay, so that is the importance of subserosal myoma. Okay, it can get detached from the uterine wall and it can go and attach it itself to the intestine or omentum. There it will get blood supply, and from there also it will get detached and will be sticking to whatever places it will be getting. So it will be called as a parasitic fibroid or a wandering fibroid. Yes, right. The next one is cervical myoma. Cervical myoma constitutes about 1 to 2% of the fibroids. This can be supravaginal cervical fibroid, which is the most common type, and it can also be a vaginal myoma. And remember, I have told you a cervical myoma can take many positions. Okay, so this can be anterior, posterior, lateral or even central. So what is the importance of all these locations? So anterior cervical fibroid is going to push the bladder. Okay, so it can result in urinary retention, and a posterior fibroid is going to push the rectum. So pouch of Douglas will be obliterated, and the lateral fibroid can either displace or compress the adjacent structures, and the central fibroid is basically going to expand around the circumference of cervix. Okay, so this is all about cervical fibroid. Now, finally, let's discuss about broad ligament fibroids. Okay, so this can be a true broad ligament fibroid or pseudo or false broad ligament fibroid, as I have already explained. Okay, now a true broad ligament fibroid is located between the layers of broad ligament. It arises from the muscle fibers of round ligament actually, or it can even be a ovarian ligament or perivascular connective tissue as well. Okay. So, what happens means when it is arising from the broad ligament as such, what it is going to do? This is going to displace the uterus medially, right? So, displace the uterus medially and there is no attachment with the uterus. Okay. So, if I draw a pic, okay, so this is the uterus. Okay. So, let us take, this is the broad ligament. Okay. Somewhere if you have a fibroid like this, so this is going to be here. Okay. And as it grows, it is going to, this is the lateral part, this is the medial side, right. So, as it is going to become big and big, this is going to give a push from the lateral side of the uterus, that will be pushing the uterus medially. Clear? So, this is a true broad ligament fibroid. And then we have to discuss about pseudo broad ligament fibroid. This also arises from lateral wall of the uterus and it will grow into the two layers of broad ligament. So, here the uterus will be pushed laterally, okay, and it is attached to the uterus by thick structure. Clear? So, uterus will be, it will be pulled laterally because this is growing and it will be pulled laterally like this. Okay. So, let us see an example of this pseudo or false broad ligament fibroid. So, this is a picture. So, I hope you are able to see here. Okay. So, this is the uterus actually. Okay. So, this is the uterus as such. Okay. And you are able to see a fibroid on the lateral wall of the uterus and there is a thick connection in between. Okay. So, it is connected to the lateral wall of the uterus. Okay. So, with this video, we are finishing leiomyoma discussion part 1. I hope you would have understood what is leiomyoma, how will be the macroscopic appearance, microscopic appearance, classification and the various types of leiomyoma and its significance. In the next video, we will be discussing about both the medical as well as surgical management of fibroid. So, until we meet in the next video, take care, happy learning and bye-bye.